Hello everyone. Today the lecture is on a very important topic which has been repeatedly asked in the examinations, and how much soever I emphasize or I stress on the importance of this topic is less. Almost every year the questions has been asked on this topic, and it is still an area of confusion among the students. The students still get the answers wrong. The topic is dislocation of hip, and we'll discuss the details, and I'll try to clarify and make you learn this important topic. So, dislocation of hip. Hip joint, as we all know, is made up of head of femur and acetabulum. It is an articulation between head of the femur and acetabulum. So, if there is dislocation, dislocation means loss of contact of the articulating surfaces of the joint, complete loss of contact. Okay, so dislocation. So, the dislocation of hip, it could be posterior, it could be anterior, and it could be central. So I will discuss all these three one by one. So posterior means on the basis of the dislocation of the direction of the head of femur, it is named. If the head of femur goes posteriorly, so this is the pelvis, this is the anterior view, okay. So if the head of femur goes posteriorly, dislocates posteriorly, this is posterior dislocation. If it comes anteriorly, it is anterior dislocation. And if it goes inside the acetabulum, breaks the medial wall and comes within the pelvic cavity, that is central, okay. So first is posterior dislocation. Posterior dislocation is the most important and most common of all three. Okay, and this is commonly asked also in the examination. Okay, so coming to the posterior dislocation, first of all, the question formed commonly is on the basis of mechanism of injury. So it is also addressed as dashboard injury. Why dashboard? Dashboard is that area which is present on the front of the car. The knees of the driver and the co-passenger lies against the dashboard. So that is the dashboard area. So you can see in the picture. I'll just zoom it in. So this area is the dashboard. Okay. Now when the patient sits, so as we sit in the car, the knees are flexed. Okay. So the hips are also flexed. Okay, because we are sitting, and the knee is lying against the dashboard. So unfortunately, whenever an accident occurs, the knee hits the dashboard, and this force is transmitted towards the hip joint. Okay, I'll just show you. This is the hip joint. The person is sitting. Okay, the knee hits against the dashboard during an accident. This force is transmitted, as a result of which the pelvis is stationary and the femur goes posteriorly. Can you appreciate it? This, yes. So this is the direction of impact which results in posterior dislocation of hip. This is an important MCQ and should be remembered. Okay, that which injury develops as a result of dashboard injury. Okay, so this is posterior dislocation of hip. Now, once the accident has occurred, the patient is brought to the casualty, and as a emergency doctor, you're called. So you'll see the patient. So what will you look for in the patient? So first of all, an important thing is the attitude of the patient. Okay, like how the limb of the patient is positioned. This is again an important question, so just pay attention. So as you can see in this patient, the left side of the patient is the affected side. Okay, now you can see that the thigh is flexed. Okay, the hip is flexed and it is internally rotated. Why am I saying that it is internally rotated? Why it is flexed? Because it is clearly above the surface. Why is it internally rotated? Because the leg is pointing outwards. Okay, So when the knee is flexed and the leg is pointing outwards, this suggests an internal rotation. And this is the midline, so the thigh is adducted. Okay, so adduction, flexion, and internal rotation. Okay, so this is the attitude with which the patient presents. Flexion, adduction, internal rotation. Very, very important. These 3 points, which are specific of posterior dislocation of hip, the attitude of the patient is flexion, adduction, and internal rotation. It should be remembered, and it is directly asked in the exam, in the questions. Okay, that patient comes to the casualty. You notice the patient that the limb is in flexion, adduction, and internal rotation. So what could be the diagnosis? Okay, and a very important point, it should be remembered. Now, what else will you look for in the case of posterior dislocation of hip? So there are other important points which needs to be mentioned. One is vascular sign of Narath. What is vascular sign of Narath? We are able to palpate femoral artery. Okay, there's a specific landmark for the palpation of femoral artery. Why are we able to palpate the femoral artery? Because the artery, okay, goes anteriorly against the head of the femur. Okay, so if the head is dislocated, so there is no bony support present posterior to the artery. So as a result of which, the vessels tend to sag backwards. They tend to sag backwards. As a result of which, you will not be able to feel the pulsations of the artery, or it will be very feeble as compared to the contralateral side. Understand? Look, why are we able to palpate the radial pulse? Why are we able to palpate the radial pulse? Because it is somewhat superficial here, and also it is lying against the volar surface of the radius. So we just press it against the volar surface of the radius and we are able to palpate it. Okay. Similarly, why the carotid pulsations are felt best at which point? Against the carotid tubercle or the Chiasognath tubercle of the C6 vertebra, because there is a bony support posteriorly. So that's why we are easily able to feel it. Similarly, for femoral artery also, it is felt against the head of the femur, but in posterior dislocation, okay, the bony support is lost, so you will not be able to feel the pulsations. So this is called as that the vascular sign of Narath is present. So absence of pulsations or feeble pulsations means presence of vascular sign of Narath. Okay. Another important thing to be noticed while examining the patient is the status of sciatic nerve. Again, this is the anterior aspect, this is the posterior aspect. Okay, which nerve goes behind? Which nerve goes behind? Sciatic nerve. So if the head is dislocated posteriorly, it will press the sciatic nerve. Okay, not in every case. The compression is not severe in all the cases, but yes, if it is quite significant, so it may lead to foot drop. Okay, so the status of sciatic nerve should also be assessed. Okay, how will you assess it? You look for the dorsiflexion of the ankle joint. Okay, you'll ask the patient to dorsiflex the ankle joint. Okay, so if the patient is not able to do it, so means the patient will have foot drop. Okay. Another thing which can be done is, as the head is dislocated posteriorly, so it might be possible for you to palpate the head through the gluteal region. Okay, so head could be palpated through the gluteal region, means posteriorly. Okay, these are all clinical aspects. These are all clinical signs which will just help you give an idea, so that okay, this could be a case of posterior dislocation of hip. Okay, but again, once you have seen the patient, you have assessed the patient, you will get an X-ray done. So what will we see in X-ray? Let's discuss. So this is an X-ray of the patient. Okay, this is the pelvis. This is showing both the hip joints. So you can clearly see that on the left side, this is the acetabulum. Okay, this is the acetabulum. This is the head. Okay, and now the head is outside the acetabulum. Okay, so this is dislocated. Okay, how will you say it is dislocated? Of course, the acetabulum is empty. And one more thing, an important line which is to be mentioned here is Shenton's line. So what is Shenton's line? This is the obturator foramen. The superior surface of the roof of the obturator foramen, okay, is continuous with the neck of the femur. Okay, if you draw a line, the line should be continuous. But in this case, one line I'm drawing here and the neck is lying here. So the Shenton's line is broken. Broken Shenton's line. Okay, another thing which you will look for is that the shaft is pointing towards the midline, that is adducted. Okay, so this adduction. Another thing is that now look towards the femur on the right side. So you can see the lesser trochanter here. Okay, but it's not visible here. Why? I'll just clarify it to you. So let's remove this pelvis. So this is the femur of the left side. Commonly when we get an X-ray done, the lesser trochanter should be visible. Okay, but not very prominently, just slightly. Okay, so if due to some reason the femur is externally rotated, okay, so it becomes more prominent. Okay, and due to some reason, if the femur is internally rotated, it becomes absent. Okay, although it's already less prominent in the normal X-ray, okay, but now in this case it becomes absent. So this suggests what? Internal rotation. This suggests that it is in internal rotation. So adduction, internal rotation. Okay, and head is lying above the acetabulum. Above means it is riding upwards. So this is what you look for in the X-ray. Just remember this X-ray, it's very important. It is even sometimes directly asked in the examination. Okay, so this suggests posterior dislocation of the hip joint. Okay, so again I'll revise the important point. It is a dashboard injury. Okay, another thing is FADIR, FADIR, flexion, adduction and internal rotation. Okay, you can also remember this by another mnemonic which we commonly use for the interossei, that is PAD. Okay, PAD, palmar interossei, causes adduction. So again, posterior dislocation of hip, you will have adduction. Okay, so another way to remember this could be PAD. So but yes, FADIR, FADIR is important. Okay, then vascular sign of Narath is present. Sciatic nerve palsy. Okay, this is in this the broken Shenton line, and the X-ray you look for the broken Shenton line, the adduction, the internal rotation. Okay, what is the treatment? What will you do? So for the treatment part, this is considered as a medical emergency. It should be reduced as soon as possible, either under the cover of analgesics, okay, or GA, general anesthesia. Okay, once it is reduced, it is commonly kept in traction for few weeks to let the ligaments and the soft tissues around the hip joint heal. Okay, if it is irreducible, we get a CT scan done, that is also immediately, and then an open reduction is planned. One more thing I forgot to mention, and which is important, is that in 50% of the cases, if the dislocation occurs, so you can see, this is the posterior aspect, this is the hip joint. Now we are looking from behind. Okay, so when the dislocation occurs, As you can see, the acetabulum provides some extra support posteriorly as compared to anteriorly. Anteriorly, you can see a larger area of the head, but in posteriorly, a lesser area of head is visible. So, proper support is provided by the acetabulum. So, when the dislocation occurs, in 50% of the cases, what might happen is that the head might take away a chip or a fragment, a part of the fragment or a chip from the posterior acetabular wall. Okay, so again, if that fragment is visible on the X-ray and seems to be quite large, so it is also reduced. But this detail is not important for you. Just remember that in 50% of the cases, it is associated with posterior acetabular wall fracture. Okay, so this was posterior dislocation of hip. Now coming to the anterior dislocation of hip, not very common, but yes, it is also a result of high velocity trauma. Okay, so in this anterior dislocation, the head has dislocated anteriorly. Okay, so again, what will you look for the features in the patient? So in the patient, you can see these two pictures, and we can just compare these two pictures later on. So the right side of this person is affected. Again, the knee is flexed. It seems to be externally rotated. Why? Because the leg is pointing inside. In a flexed knee, if the hip is internally rotated, the leg goes outwards. And in a flexed knee, if the leg is externally rotated, then the leg goes inwards. Why the knee is flexed here? Because the hip is flexed. Okay, so hip is flexed, as a result of which, to support the limb, the knee is in flexion. Okay, and it seems to be in external rotation. Look at the position of the foot here. This foot is pointing outwards, and this is just in neutral position. So this person has flexion, okay, abduction, and external rotation. Okay, so this is Faber, abduction. From the midline, the thigh is pointing outwards from the midline. Flexion and external rotation. Okay, so Faber. That was Fader. This is Faber. Again, very, very, very important. Directly they will ask in the examination that, okay, if the patient has this kind of deformity, what will you suspect? Okay, another patient I'll just show. So this patient has problem in the left lower limb. So again, it is flexed. Okay, it is abducted. This is the midline. It is completely pointing all the way outwards, and it is externally rotated. Okay, so this is the clinical feature which is seen in anterior dislocation of hip. Coming to the extra part of the anterior dislocation of hip. Now again, what will you look for? This is the acetabulam. Okay, this is the broken Shenton's line. The hip is dislocated. The head is lying below the level of acetabulam. Okay, in that case it was lying above the level. It is lying here. In this case it is lying at this level. Okay, externally rotated. Can you see the prominent lesser trochanter? Externally rotated. Okay, so this is what picture looks like. Dislocated, externally rotated. Okay, fine. Now, and this is the midline. This is the midline. So it is in abduction. So flexion, abduction, and external rotation. Again, closed reduction under general anesthesia or under the cover of anesthetics should be done. An important feature which I forgot to mention in posterior dislocation of hip is this is a medical emergency. Why this is a medical emergency? Because if prolonged too much, then it will lead to avascular necrosis of the head of femur. Why? Because the supply is very peculiar, and if it is dislocated, the vessels get compressed or get torn off, as the result of which the supply is lost, and this leads to avascular necrosis of the head of femur. So it is to be reduced as soon as possible, no delay. The third type is central dislocation, known as central fracture dislocation. Okay, this is actually central fracture dislocation. Not very important, but yes, it should be mentioned. So central fracture dislocation, you can see that the head goes directly through the stipulum and enters inside the pelvic cavity. So it always leads to the fracture of stipulum. So you can see that the head has entered inside the pelvis, and these are the fragments. The columns have broken. This is the fracture. This is the fracture. Okay, so it should be operated. Commonly it is operated nowadays, and for temporary relief, traction is applied. Okay, so not much details are required for central fracture dislocation. Yes, one important point to be remembered is that this is the only condition in which per rectal examination could be done. So the head can be palpated per rectally. Okay, so per rectal examination just remember this point. The details are not very important. Okay, so this covers the dislocation. Okay, and we'll just discuss some questions related to dislocation. So first is, a patient was brought to the casualty following an accident. On examination, his right lower limb was short, internally rotated, flexed and adducted. Okay, at hip. The most likely diagnosis is posterior dislocation of hip. So it is internally rotated, it is flexed, it is adducted, and it is short. Yes, it will be short because look, the head is gone upwards, okay, behind and upwards. So this leads to limb shortening. Okay, but in anterior dislocation of it, the head comes downwards. Okay, so the length is increased. Okay, so there will be lengthening in anterior dislocation of hip, and there will be shortening in posterior dislocation of hip. Okay, so the answer to this question is posterior dislocation of hip. Again, what is the likely diagnosis of the condition in the image below? Yes, this is clearly posterior dislocation of the hip. The head has gone outside, it is internally rotated, it is adducted. Okay, so and there is shortening. Okay, because the head is gone upwards, although it is not evident here, but yes, just go by adduction and internal rotation. Okay, so this clearly suggests posterior dislocation of hip. Okay, so there will always be a confusion between anterior dislocation of hip and posterior dislocation of hip. So just keep on revising and keep on remembering these x-rays and Faber and Fader. Faber for anterior dislocation of hip and Fader for posterior dislocation of hip. Vascular sign of Nahardt is positive in posterior dislocation of hip. So this covers a very important topic.